study group. And our today's topic is antiarrhythmic medications, an update. It will be presented by none other than our beloved Dr. Rafique Ahmed sir. As the protocol before the start of the lecture, I'd like to request Dr. Abdul Jamil sir to say some words regarding our beloved Rafique Ahmed sir, and then start the session. Jamil sir.
Assalamu alaikum. Thank you, Tushar. Regarding Rafique sir, nothing special, new things to be added. He is always with us and he is a great teacher. Today's topic is important.
Jamil, mute here, sir.
Audio.
So, today's topic is on cellular electrophysiology and pharmacology of antiarrhythmic medication. This is a very important topic, and medication is always needed to control the arrhythmias. So we'll be able to learn many things from Sir, and he's a great teacher. And let's go to the topic. Sir, please.
Good evening. Thank you all for joining. So Tushar asked me to give a lecture on antiarrhythmic medication, and the clinical part is simple. Everybody can read in the book. So I thought that I will just blend in how the medicines work and what is the rationale for using these medicines. At the bottom of this, I mean, if I go to the at a ion channel level, action potential is what drives the heart, and which is basis of normal rhythm and also abnormal rhythm. So this is a cell, as you know, outside predominantly sodium, inside potassium and calcium. And there are channels which regulate these electrolyte movements, and they generate the action potential and subsequent contractility of the heart. So these are the channels. The cell membrane is a bilipid layer, and there are channels. And these channels, they have been extensively studied. It always fascinates me, and I forget it, I go back, read about it. So that's the way it is, that it's not something that I will remember or you will remember unless you go back and read about it. It's more important today than when I was a medical student, because a lot of the medicines that are being developed are targeted towards these channels at a molecular level. So it is important that you all have good understanding of how these medicines work. And this will also explain the mechanism of the action of these medicines, plus also sometimes the side effects. Ion channels, what happens, this is the resting state. It is the channel is closed. Actually, at this point, it is called inactive state. That means it is actively closing the gate, kind of. And then when it opens it, that's when it's activated to open and becomes inactive in this phase, and then again gets to the closed state. And so how is it controlled? So if you look at this channel, and the gate can be in different location. And so this is a sodium channel. There is a gate, it opens up, and then once it is stabilized, and so let's say I use a drug called lidocaine, it can close the gate and control the entry of sodium into the cell. And it has a specific receptor. Now, if you look at this, the receptor has been shown here, but if you look at this calcium channels blockers, this is diltiazem, nifedipine, and verapamil. Look at they're working in different locations. And these are not just imaginary, somebody put dot in this level. This has been studied to identify where they're located. And depending on that, their action is different. If you know that verapamil is an antihypertensive vasodilator plus an antiarrhythmic, strong, diltiazem, nifedipine is mainly an antihypertensive, no antiarrhythmic action, and diltiazem in the middle. So depending on where this channel is blocked, activity of these drugs differ. How does it happen? So this is action potential of the sinus node. Sinus node activity is driven by calcium current, as opposed to ventricular myocardium. If you see, there is entry of sodium, which creates the action potential. So the sinus node, once the action potential starts, there is influx of calcium. And that's why drugs like lidocaine doesn't have much action on sinus node function. And to start the process, there is an upstroke, which is a spontaneous depolarization, and it is controlled by what we call funny current. It's a potassium channel, potassium current. And this funny current, we have a new drug called ivabradine, which works on this, and it can slow down the sinus rate. This funny current is also influenced by sympathetic tone. So that's why beta blockers can slow down sinus node function. And this is ventricular myocyte action potential. Once action potential initiated by some kind of stimulus, there's influx of sodium. And then there is this portion, it then depolarization starts. And here you can see it comes down because of potassium current, and rest of it, there is a fight between potassium going out and calcium coming in and sodium being extruded, and then it comes back to the resting level. I'm going to skip this slide. So this is, again, the same slide is showing different current, but I try to remember in this kind of graph, any electrolyte going inside is put under the line, and coming inside, outside, going extruded is put on the top. So if you can say sodium, massive amount of sodium comes in and depolarizes the cell, and then calcium maintains it for a little bit, and then potassium brings it back to resting level. And there are different kinds of potassium current, IKR, IKS. You don't have to remember, this is the funny current, which is present in sinus node. But it's interesting that if you look at sinus node, as I mentioned, there is almost absent sodium channel, and sodium activity is irrelevant in sinus node function. And then calcium, of course, is important. And then this acetylcholine dependent, and this is the channel that can be influenced by acetylcholine, and also this one, IKF, sympathetic norepinephrine, can affect this one. And that's why both of these increased parasympathetic activity or decreased parasympathetic activity and increased sympathetic activity can change the sinus node function. That's why the beta blockers work. Or if I can use an anticholinergic medication like atropine, sinus rate will go up. What is the difference between the atrium and the ventricle? In atrium, there is the funny current, which is IK1. Same thing is funny current is present in His-Purkinje system. That's why the His-Purkinje system can itself generate impulse, just like sinus. So if the sinus node goes, so the AV node and His-Purkinje has their own funny current, which can produce the activity and spontaneous depolarization. So at a macro level, so at a cellular level, how can arrhythmia happen? Enhanced automaticity after depolarization. We have talked about it many, many times. Early after depolarization, delayed, and re-entry. So this is basically, there's a speed, and then it gets faster. And the typical example is sinus tachycardia. And then we have other kind of enhanced automaticity that can cause this kind of arrhythmia. Delayed after depolarization and early after depolarization. Delayed after depolarization happens a little bit after the action potential is completed, and early after depolarization happens in the setting of long QT. And if it is big enough, it can produce a rhythm. And the examples of early after depolarization, torsade and long QT arrhythmia, but delayed after depolarization happens like digital toxicity, accelerated idioventricular rhythm, reperfusion, arrhythmia, and this is catecholaminergic polymorphic ventricular. I'll come to this interesting thing because delayed after depolarization happens later, little bit later, and this is due to calcium accumulation inside the cell. And this happens in digital toxicity that can cause it. Reentry, we have seen this slide, a simple formula. If I take a tissue and there is a center, a gap, and then if I put electrical stimulus here, it goes on both sides and then collides and extinguishes. However, if there is a block here and I introduce a stimulus, it will be able to go in one direction and block in one direction. And then if I take it off, it won't go any further, but this will continue down. And as long as there is a tissue which is not refractory ahead of it, it can then continue round and round. And guess what? If I give a medicine which can make this tissue refractory, or over here, this tissue refractory, that by the time it comes here, if this tissue is refractory, then the arrhythmia will not continue. And that's the mechanism of action of some of the antiarrhythmic drugs, that we prolong the refractory period and we can stop the antiarrhythmic medicine. But on the flip side, if you give drugs like flecainide to a patient with myocardial infarction, you can actually cause a critical slowing of the scar and develop incessant ventricular tachycardia when you are not expecting it. So it's a kind of double-edged sword that we need to know which drug to use where and how to prevent this incessant arrhythmia related to the drugs. The re-entry barrier can be anatomic barrier, such as a scar tissue, or it can be a functional barrier, like electricity goes and they penetrates and create a functional block around which the re-entry can happen. So this is an example of a myocardial tissue. This is normal tissue and there is scar, and electricity can go down slowly through so these are the scars, and this is the normal tissue. So electricity can go slowly through these and then go around and produce this re-entry circuit. And there are different pathways, and you can find this. And then, of course, a simple mechanism would be that if I give an antiarrhythmic and if I can block this, the arrhythmia will stop. Or I can put a catheter here and ablate it, and we can stop this arrhythmia. But on the other hand, if I slow it enough, but not completely, then it can produce incessant tachycardia. And as I mentioned, this happens in patients with a history of myocardial infarction if they're given drugs like class 1C drugs. And that is one of the mechanisms of proarrhythmia with these drugs. The AV nodal reentry, we have seen this before. We can have reentry in the AV node. There is a slow pathway, electricity go down to the slow pathway through the AV node and then comes back. And if the slow pathway is open again, it can go round and round and produce this reentry. But this is the commonest form. It's a benign arrhythmia because it is supraventricular arrhythmia. What are the mechanisms? So we can have an anatomic substrate like WPW syndrome. Ischemia can create a substrate for reentry or arrhythmia genesis. Myocardial infarction produce scar, can produce substrate for reentry. There can be age-related fibrosis. I put a question mark, and a lot of this because we didn't know, but now we also are finding out that sometimes patients get amyloid deposits and they can develop fibrosis. And there is another one, stretch activity channel, that stretching of the heart in cardiomyopathy can cause arrhythmia. And that's why that some of the ACE inhibitors and beta blockers may work as antiarrhythmic because they reduce this. Antiarrhythmic drugs, there is a classification, and this is, we all should remember, this class 1 drug. These are the sodium channel blocker, class 1A disopyramide, quinidine, procainamide. This is still available. Both of these drugs are available, but not used as much. Then class 1B, lidocaine, mexiletine, tokenide. Tokenide, I have never used. Mexiletine is used. This is oral. Lidocaine is intravenous. And then class 1C is flecainide and propafenol. And class 2 is beta blocking medication. Class 2. And then potassium channel blockers. The first one that came out was amiodarone. And it was found at Oxford, Dr. Williams' lab. And then sotalol, ibutalide, and dofetilide. Ibutalide is an intravenous preparation. We use it for conversion from atrial fibrillation flutter to sinus rhythm. And dofetilide is being used more and more than before. And then, of course, we have calcium channel blockers. So this, please look at this carefully. So I'm going to come to a little bit randomly. This is a channel. This is NCX, sodium calcium exchange channel. This is very important. There are a lot of drugs being tried and NCX inhibitors. The reason NCX inhibitors are used is in heart failure patients, there is imbalance of intracellular calcium. And question would be intracellular, there is intracellular depletion of calcium. And if we use NCX inhibitor, it can increase contractility. That's the premise of this study. And these are I don't think there is anyone in the market at this point, NCX inhibitor, but these are still being studied. And the study has been going on for quite a few years. And then look at this, another channel. This is ryanodine receptor. This is a sarcoplasmic channel. And in the sarcoplasm, there is calcium, so it controls calcium. And if there is problem with this one, it can cause arrhythmia like catecholaminergic polymorphic ventricular tachycardia. Recently, Atahar had a patient, and drugs like carvedilol and flecainide works here. And there is another group of drug being developed, it's called Rycels, to block this channel, to see if they can increase myocardial contraction, can be used for arrhythmia. Then, of course, we have funny current here that we use like vibradine, class 2-1 beta blockers, and the sympathetic channel, and then class 3 drugs works in this channel. Look at a drug that ranolazine, which is actually a anti-anginal medicine, but it has a class 1 action. And we sometimes use ranolazine in combination with amiodarone to treat refractory atrial fibrillation. So class 1 antiarrhythmic drug, sodium channel blocker, the most potent one are flecainide and propafenol. And the weakest one are the class B, which is lidocaine and mexiletine. But these are also the safest. Lidocaine works intravenously. Mexiletine is a drug that we use if somebody has refractory ventricular arrhythmia. We sometimes use it as a solo drug or in combination with amiodarone. It can be combined with amiodarone. This is one drug that can be combined with amiodarone. There is another drug that we used to combine with amiodarone is procainamide, which is not much available. And then class 1A, intermediate action, will be quinidine, procainamide, and disopyramide. These are all drugs, plus please don't forget them. Unfortunately, in Bangladesh, a lot of these drugs are not available. And I think after today's lecture that you should try to talk to the pharmaceutical industry to have some of these drugs available, because we have a population of 150 million. Even if these drugs are needed in small number of patients, that will create. Can you turn the? Can you mute yourself, please, when you talk? So class 3 antiarrhythmic are the potassium channel blockers. They prolong action potential and effective. That's how they work as antiarrhythmic. But some of these agents also have beta blocking action, calcium channel, sodium channel blocking. And drugs are amiodarone, sotalol, ibutalide, which is available intravenous preparation for acute conversion of atrial flutter fibrillation to sinus, and dofetilide. Calcium channel blockers, they work on calcium channels, and the mechanism is a little vague because you see, this is in sinus node, there is calcium current. To influence this one, we really need a high dose of calcium channel blocker, which we rarely give. And then there is some action here in the ventricular myocardium. And some of the ventricular arrhythmias are calcium current dependent, and that's why rarely we have used combination of calcium channel blocker. And one of the arrhythmia that responds to is adenosensitive ventricular tachycardia responds very well to calcium channel blocker. So how does it work? Decreasing automaticity. So how can you decrease automaticity? So if this slope, if we decrease the slope, it will take longer for the action potential to start, and thereby we can slow down an arrhythmia or heart rate. Or we can decrease the diastolic potential so that once it goes down, we take it further down. Again, it will take much longer time to come up. We can also say that once the diastolic potential reached here, we develop an action potential. If we can increase that threshold, then it will take longer and we can decrease the rate of the arrhythmia or prevent it. And the other mechanism, of course, we prolong the refractory period. And mostly this is done by a class 3 antiarrhythmic medication. Increased refractoriness. Typical example is class 3 antiarrhythmic like amiodarone, sotalol. It can prolong the action potential and thereby increase the refractory period. However, sodium channel blockers, even though modest, it changes the slope just a little bit, that the effective refractory period, it can prolong the refractory period of the tissue. So antiarrhythmic action of in delayed after early after delayed after depolarization can be treated by verapamil, because delayed after depolarization is due to calcium current, and verapamil is helpful. And like catecholaminergic polymorphic ventricular tachycardia, if we know that this is catecholaminergic polymorphic ventricular tachycardia, they can be treated with drug like flecainide in a very, very selective group of patients. They're worsened by increasing heart rate. That's why combining with a beta blocker can be of help. Early after depolarization, we need to shorten the action potential. So we can use magnesium, or we can use any drug to increase the heart rate. Like we can use isoprenoline for a short period of time, or we can use a temporary pacemaker to shorten the action potential duration. One concept that you need to understand, that state-dependent block. Some channels work when they are active, antiarrhythmic medicines, and some during resting state. Class 1 drugs work when it is active. That's why class 1 drugs like flecainide, lidocaine, they work very well in the setting of fast heart rate, such as ventricular tachycardia or atrial fibrillation. Class 3 drugs, what happens with them? The faster the heart rate, the less effective they are. That's why they work better at a slower heart rate. And this is a concept. It's a use-dependent concept. Just keep that in mind, that this is something that happens with the drugs. So a lot of the class 3 action, if the rate goes up faster, a lot of the efficacy of the drug is lost at a faster heart rate. Toxicity of the drugs can be related to the mechanism of action, like I'm prolonging the QT interval or refractory period, and I'm making these patients prone to torsade. So this is due to mechanism of action. The conduction slowing can produce incessant tachycardia, like flecainide-induced VT in post-MI patients, even though we don't use it anymore for that purpose. Or QT prolonging drugs can cause torsade. I mentioned that before. It's something a little bit more common in women, probably related to estrogen. So what do we need to do to treat antiarrhythmic drug use? First of all, we need to identify and treat the precipitating factor for arrhythmia. And for any arrhythmia, we have to establish a treatment goal. What am I trying to do? Am I trying to make the patient feel better only? Am I trying to prolong the life of the patient? These are the two things that, and the other thing that we look at these days is reduce hospitalization, minimize risk. Antiarrhythmic drugs can cause arrhythmia. So we have to keep an eye on it that we do not develop proarrhythmia. And that's why when necessary, we monitor drug level or other things that look at, like if somebody is taking sotalol, we look at the QT interval. If somebody is taking flecainide, we look at the QRS duration. At the same time, we check the electrolytes. So I'm going to start with some of the drugs. Adenosine, available in Bangladesh, short half-life, highly effective intermittent SVT, and this is not used long-term, so we don't worry about the side effects. Even though when you give this medicine, you have to always do it and monitor. Very rarely, I mean, I have seen 2 cases, many years, had like 30 to 40 seconds of asystole after adenosine, but that's rare. And that will eventually, the rhythm will come back. Digital is still used. It can be used for patients with AFib, with rapid ventricular response, in whom we are finding difficulty in controlling the heart rate because we cannot increase the beta blocker or calcium channel blocker due to low blood pressure. Digital is a good drug as long as we keep an eye on it. Interestingly, during pregnancy, supraventricular tachycardia, Digitalis is a drug that has been studied, used, and it is effective with minimal side effect. So in pregnancy, this is actually a drug of choice if we have to use any medicine. During pregnancy, we try not to treat any arrhythmia. I had one patient with ventricular tachycardia, incessant ventricular tachycardia with heart rate around 120, 130. We just left the patient in VT during the whole pregnancy, and she did fine. So how did we do? We kept a close eye on this patient. So we follow them very carefully and tell them that if you develop heart failure symptom, come to the hospital. Otherwise, we did not give that patient any medicine. Flecainide, it is a class 1C drug. It has anticholinergic property, highly effective in atrial fibrillation and WPOD syndrome. As long as it's a structurally normal heart, it is a very safe drug. So what we do nowadays, that if I'm using it in a 45-year-old female without any history of chest pain or no, MI, and normal ECG, I usually say fine. But in a little bit like if I have a man in his 50s, we try to do an echo. Echo was done on everybody, sorry. But we also do nuclear stress test to rule out myocardial ischemia or any evidence of scar, because there is increase in mortality in post-MI patients with flecainide. The drug has no long-term side effect. We can give 25 milligrams BID is the lowest dose, and then increase to 200 milligrams BID. I have rarely used 200 BID. I have some patients on 150 milligrams BID. Majority of the patients will respond within 100 milligrams BID. There is a strategy of pill in the pocket. That means if somebody has atrial fibrillation and well documented, a relatively young person, and it happens once or twice a year and lasts for several hours, you can actually give single dose of 200 milligram of flecainide. So what I tell patients that, look, if you start developing palpitation and it is atrial fibrillation, some of the patients can now do home monitoring with iPhone or other home monitoring devices available, and tell them to take single dose of flecainide. But if you do that, we tell them stay home, because sometimes when they convert to normal rhythm, they can be bradycardic for a period of time. And if they're driving or doing something, they may pass out. We still tell them to stay home and not to drive.
Sir,
Yeah.
Sir, just to interrupt you, many a times, as it is written in the guidelines also, the presence of structural heart disease, even including LVH. So if the patient doesn't have scar tissue,
Yes.
Is it very harmful for the patient to use flecainide or propafenone? Because we don't get off-label use we have done, but we don't get that much harmful effect with flecainide or propafenone in VT patients or AFib patients with just LVH or without evidence of scar.
Yeah.
But the guideline says you can't use. That's why I asked.
Yeah. So the question is that what is structurally normal heart? For flecainide, we are very strict with this. For propafenone, actually, propafenone has beta blocking action, and propafenone works very well with left ventricular hypertrophy. I had one patient who was doing very well on flecainide, 150 milligrams BID. She developed unstable angina, but she did not have an MI. And I discussed this with the patient. I continued flecainide and did fine. But I think there is a new study which showed that in any form of coronary disease, in flecainide, there is actually adverse outcome. So we just avoid it in patients with coronary disease nowadays.
Sir, I think I'd like to add one comment, if you may.
Sure.
With the flecainide particularly, because if you have mild LVH without any other obstructive coronary disease, I think it's fairly safe to use it. Of moderate and severe LVH, there's a concern. And if you want to be very sure in advanced centers, if they have cardiac MRI with late gadolinium enhancement, it might not be appropriate to Bangladesh, but late gadolinium enhancement, you can see if there's a fibrous tissue, then you know that in certain areas there's a chance of scar more, then you should not use it. And the study that came out from Emory, I think recently is published in JACC in July. I think they studied like 4,000 people, around 5,000 people actually, over 20 years. If they have like non-obstructive coronary artery disease, non-obstructive, then you could still use the flecainide because they did better than the class 3 drug. But if they have obstructive coronary artery disease and a scar, definitely you should not use it. They have more adverse outcome. It was published in July in JACC magazine.
Yeah, so great. So the issue of left ventricular hypertrophy, why the grade? Let's say somebody has hypertension and mild LVH. This is basically symmetric left ventricular hypertrophy without any scar. However, we do not know if they are hypertrophic cardiomyopathy because those group of patients can develop scar. That is the problem. So we have to use a clinical judgment. Even mild or even moderate left ventricular hypertrophy in a patient with long history of hypertension, I think can be used as long as we can, but the guidelines are a little bit strict. But this is a good drug to have in mind. I understand that it is not manufactured, and I think as a group, you should talk to the pharmaceutical industry that one of the companies at least should bring. I remember many years ago, we lobbied to have sotalol available, and sotalol is available, and this drug should have it available in Bangladesh. Right now, you have to get it from India. Propafenone is also highly effective for AFib. It's a class 1C drug, but it has some beta blocking property. And this drug is actually indicated if there is left ventricular hypertrophy, it's a good drug. But again, structurally normal heart without significant coronary artery. Dose is 150 milligrams TID to 300 TID, total daily dose of 900 milligrams. Long-acting version, 225, 325, 425 BID. Problem is long-acting, it's pretty expensive long-acting drug. So we end up using the regular one because a lot of insurance will not cover the long-acting drug. So I think between these two class 1C drugs, both of them are very effective, at least we should have one of them. And if I have a choice, I have a flecainide available in Bangladesh and talk to the pharmaceutical industry to have this drug manufactured in Bangladesh. Quinidine is an old drug, but interesting that this drug is the only drug that has been found to be relatively safe in second and third trimester of pregnancy. We don't use it much. It also has new use, the Brugada syndrome patient. You can use quinidine. I don't remember when was the last time I used quinidine, but the quinidine sulfate dose is 200 to 600 milligrams, Q6-hour extended release. Gluconate will be 324 to 648 BID, and sulfate 300 to 600 BID if the drug is available. Procainamide is another drug that is, we used to use a lot of intravenous procainamide. Since IV amiodarone came, it has become less and less used, but I think this is the best drug for WPW syndrome with AFib and rapid ventricular response. It is the safest and the best. As a matter of fact, when you give intravenous amiodarone, its action is mainly class 1 action, not class 3 action. So basically, you are giving an expensive intravenous procainamide. The name is amiodarone. The dose of procainamide is 20 milligram per minute intravenously for 25 to 30 minutes, which will be a total of 500 to 600 milligram single dose in patients with WPWS. And you'll see that if you find this patient, they convert to normal rhythm, or at least slow down the rate. Sotalol is available. It's a class 3 drug with non-selective beta blocking property. It prolongs the action potential duration by potassium channel blockade, and it's a mixture of D and L sotalol. Now, the problem with L part is that it is the beta blocking part, and it makes heart rate slow. So there is a trial to develop a pure class 3 D-sotalol. Unfortunately, this drug, when it was given, it increased mortality. So it never came to market. Sotalol use atrial fibrillation. That's the indication now. Ventricular tachyarrhythmia, we use it in conjunction with ICD. Let's say somebody has EF of 35%, has a defibrillator, and getting recurrent ventricular shock for ventricular tachycardia. We can use sotalol to reduce the number of shock, but not to increase mortality. It's difficult to use in patients with EF less than 30% because it can precipitate heart failure symptom. And the dose, people use 40 milligram BID of sotalol, but that's just a beta blocker. So with 40 milligrams BID, there is no antiarrhythmic action except for beta blocking function. If we want any kind of class 3 action, you have to give 80 milligrams BID, and up to 160 BID is well tolerated. Please remember, when you give 160 BID, you are giving total of 320. The rate of torsade goes up significantly over 320. I have very few patients with 160 BID. Majority of them I stop at 120 milligrams BID. For renal failure, you cannot decrease the dose, you have to decrease the frequency of use. That means if the GFR is between 30 and 60, you use 1 tablet a day, not 80 milligram or 40 milligrams BID or 60 milligrams BID, it is once a day. If the GFR is between 10 and 30, then every 48 hours. So it can be used in renal failure, but the dose adjustment should be made. Otherwise, you'll end up with torsade.
Can I ask you one question, Dr.
Yes.
Ahmed? The very good point you're making that some patients normally start 80 twice a day, but if we slow down, lower the heart rate because of the bradycardia itself, then it becomes only beta blocker. In that situation, if there's indication of sotalol, should you think about putting a pacemaker before we give the 80 twice a day?
Yeah. So the question is that, let's say I give somebody 80 milligrams BID or 120 BID and becomes bradycardic. Am I going to put a pacemaker? Yes or no? This is a big problem because it depends on the age of the patient. Let's say I find that somebody is doing extremely well on 80 milligrams BID of sotalol, no recurrence of AFib, heart rate is 40, 45. Then I will use it, a pacemaker. But if the efficacy is not proven, then if I put a pacemaker, then I have a situation where I'm giving a pacemaker for this reason and I cannot use the medicine because it doesn't work. So yes, definitely, we have used in some patients pacemaker in combination with antiarrhythmic drugs. So that's something that you have to keep in mind. Side effects, torsade is the main side effect. If the dose in 24 hours is less than 320, torsade rate is 1.6% or less. As soon as you go up, it increases significantly. Of course, other side effects are similar to beta blockers, as Aziz mentioned, that they become bradycardic. And if we find that the medicine is really, really effective and we want to use it, then sometimes we put pacemakers in. It is cleared by the kidneys, as mentioned above before, that you must adjust the dose. There is a protocol. We get ECG. Once we start sotalol, we get here in the United States, it's mandatory for us to admit this patient to hospital for 48 hours to start sotalol. I have still used it as an outpatient. And the way I do it, if somebody is in sinus rhythm, I feel comfortable using it as an outpatient. However, if somebody is in AFib, what can happen that we start the sotalol, and if they convert to sinus rhythm and they have a bradycardia first PUA, that's when they're going to develop torsade. So that's why we need to admit this patient to hospital for 48 hours. Dofetilide, this is another drug. This came out quite some time ago. When it came out as a pure class 3 drug, which is a pure class 3 drug, but didn't become very popular, mainly because one of the indication is AFib, but you have to admit this patient to hospital. But we are using it more and more now. 125 microgram BID, 250 microgram 5. The good thing about this medicine, it doesn't slow down the heart rate. It has no effect on cardiac function, and you can use it in patients with cardiomyopathy without any problem. Of course, there is some dose adjustment. You don't decrease the frequency, you just decrease the dose. If the creatinine clearance is over 60, you can use up to 500. Creatinine clearance 40 to 60, 250, and then 20 to 40, 125 microgram BID, contraindicated below 20. And the other part that we do during dosing, we start at 125 microgram BID, look at the QT interval. And then if the QT is acceptable, then we gradually go up to the desired dose. Now, so when these drugs came out, there are a lot of studies going on to see if the antiarrhythmic drug is safe or not. So there is a study done in Scandinavian country, published in 1999. They took 1,500 patients, ejection fraction less than 35%, and randomized to dofetilide and placebo. And the main purpose of the study was that, is there any effect on survival? And if you look at it, that dofetilide and placebo, there is no difference in survival. That means this drug is safe to use in patients with cardiomyopathy. It does not increase mortality. And then if you look at survival, if the patient had AFib and no AFib, survival is same. But the hospitalization in patients who had AFib in the setting of cardiomyopathy, their hospitalization rate was decreased by dofetilide. In patients who had no AFib, dofetilide does not have any impact on hospitalization. But what did it do AFib? For AFib, it decreased significantly the amount of AFib the patient was having. And this drug, now we use it a lot. We have to admit the patient to hospital. We can use it in patients with cardiomyopathy or normal heart muscle function. It has no effect on the heart rate. So it's a pretty good drug. Unfortunately, it's fairly expensive here to use. And the other time that it is being used very widely, that post-ablation patient, when patient go undergo atrial fibrillation ablation, we can use it. And the best part is that this is a drug which has no impact on mortality in any group of patients with or without cardiomyopathy. So you can use safely for atrial fibrillation in any kind of clinical scenario. Amiodarone, of course, is the master drug. I mean, it's widely used because you can use it as an inpatient, outpatient, but we are using it less and less, and for various reasons. It's an analog of thyroid hormone, highly lipophilic and concentrated in many tissues. This is a problem. It goes in every tissue of the body. It can go to the brain, wherever there is fatty tissue or something. It will extremely long half-life of 58 days and range, look at the 15 to 140. That means even if you stop the drug, it takes few months for it to wash out. The interesting part is the potassium channel blocker, but it also has some sodium channel blocker and then NCX channel blocking action. And it is also non-competitive. So it's a wonderful drug that has multiple effects. Unfortunately, the side effect is the problem. And thereby, there was a drug developed, which is dronedarone. I'm not mentioning it today, without the side effect. Unfortunately, dronedarone did not prove to be as effective as amiodarone. So not as used as much nowadays. In USA, it is officially approved for VTVF, but because it has no mortality benefit, VTVF. But remember one thing, it has no mortality benefit in post-MI patients with cardiomyopathy patients. It is not approved for AFib, but we use it a lot, especially in the setting of cardiomyopathy. Because what happens if somebody has EF of like 10%, you can use amiodarone without any drop in blood pressure or heart rate. Also, please remember, I go back to dofetilide. Dofetilide also does not have any effect on blood pressure. But amiodarone, we don't use it as much as before. And there are very, very selected scenarios that we are using it. And I'm going to mention that to you. So does it work? Yes, it is effective, but there is a study comparing amiodarone versus sotalol placebo. You can see that clearly amiodarone is superior to sotalol. But this is a small study. And in ischemic patients, sotalol and amiodarone is similarly effective, but the sample size is very small, so I'm not sure how to make of it. But of all the medicine that we have, especially in patients with structural heart disease, amiodarone is the best drug. But the side effect, look at the side effect profile. You can have acute pulmonary toxicity. And if you develop acute pulmonary toxicity, pneumonitis, it can be life-threatening. Patients can die. I mean, it's rare. I have seen one patient in many, many years. A patient was on a big dose of amiodarone. And then 2% patient develop hyperthyroidism followed by hypothyroidism. This is very common. Liver toxicity, 1%, optic neuropathy, blindness, that's been reported, but the cause and relation has not been proven. Corneal microdeposit happens in more than 90% of patients with long-term skin discoloration, photosensitivity, and then sometimes neurologic toxicity. So sometimes patients will come to you after you start a new medicine and say, Doctor, I don't feel good. Please don't ignore that. We had patients who came with like paresthesia or ataxia, and once we stopped the amiodarone, they felt better. So anytime you start a new medicine, please pay attention to what patient is saying and don't just ignore it and then stop the medicine. I explained to the patient, look, I'm going to stop the medicine. If your symptom gets better, that means this is the medicine. If not, then we can restart the medicine if needed. But please remember the side effect profile. We clearly discussed this. The problem is that some of the side effects are irreversible, like hypothyroidism, irreversible. Microdeposit will not wash up, skin discoloration, permanent. And then, of course, so some of the side effects are permanent. Only good news, it doesn't affect the kidney, so you can use it in patients with renal failure without any problem. So when we start patient on amiodarone, we do a baseline chest X-ray. We check the thyroid function, liver function. We do pulmonary function test with DLCO, diffusion capacity of carbon monoxide, because the earliest sign of pulmonary toxicity will be decrease in DLCO. So we need to have a baseline. If the patient is on digoxin, we check the digoxin level and we check PT-INR if they're on warfarin, because amiodarone can increase the PT-INR. And during follow-up, we check this thyroid and liver function every 6 months. If patient develops any symptom, like somebody is more short of breath than usual, I will do a pulmonary function test to see if the DLCO is going down. We try to avoid these medicines in COPD patients. Very rarely I have used this in patients with COPD, but with caution, with a clear baseline function and clear understanding with the patient that, look, you have no other medicine that I can use. I'll try it to see how you do. I examine if there is any visual symptom. Usually they get halo or kind of sensitivity to light, and then we do the slit lamp exam to see if there is any microdeposit of thyroid. But these tests should be done. So atrial fibrillation, I'm going to do another 5 minutes or so. That for management of atrial fibrillation, class 1C drug, if structurally normal heart, we can use sotalol before amiodarone. But of course, if the EF is low, we cannot use it. Amiodarone should be the last drug, especially in young people. Nowadays, definition of young is 60 to 70 for us. We use it if somebody is over 80-year-old, you can use amiodarone, without much of a problem, because how long somebody who is 85 is going to live. But this will be the last drug to use. SVT, of course, beta blockers, calcium channel blocker, flecainide profen, ablation, of course, is the best choice for SVT. Idiopathic ventricular tachycardia. If we want to use medicine, which normally we try to do, calcium channel blocker, beta blocker, and in selected cases, if we are not planning ablation, then flecainide can be considered. Of course, after beta blocker, calcium channel blocker, most people will send this patient for ablation. VT with structural heart disease, class 1 drugs have been shown to increase mortality. They should be avoided. But saying that, if somebody has a defibrillator, we sometimes use mexiletine. Mexiletine is a fairly neutral drug. Amiodarone itself has no mortality benefit in patients with VT and structural heart disease. And sotalol amiodarone, we sometimes use it in conjunction with ICD to reduce the number of shocks. I'm just going to go through a few studies, just if you permit me. We still have some time. So this study, physicians who are young probably may not remember, this study was published in late 80s. At that time, flecainide was used extensively to suppress PVC because the concept was when you reduce the number of PVC, there will be increase in survival because increased, this is the part. The study showed that if somebody has more PVC, they are at higher risk of dying suddenly. So automatic assumption was that if we decrease the number of PVC, people will live longer, without ever proving that that's true. And the drug that was used at that time was flecainide, because flecainide used to be called PVC killer. And they decided 1987, post-MI patients, to suppress symptomatic ventricular premature beat. Look at this. Placebo was better than flecainide and encanide. Flecainide and encanide clearly increased mortality significantly, and that was the first time it showed that the drug can actually kill patients, even though the intention was great. CHF stat study, then the question was, amiodarone, we use it a lot, amiodarone works for VT, does it improve survival? Look at this CHF stat study, that overall mortality was no better than placebo, sudden death, no difference compared to placebo, and ischemic, there is no difference between placebo. With non-ischemic, there is a borderline difference, but then the number of those. So amiodarone does not improve survival. So why should I use a medicine that doesn't prolong life with so many side effects? And that is the reason that we use this medicine less and less in the United States and all over the world. The use has gone down, and I hope that in Bangladesh, you do the same thing. I have seen patients who are put on amiodarone for ventricular premature beat. I consider that almost like a criminal activity to put amiodarone, to put patients on amiodarone for ventricular premature beat. There are multiple other studies. All these studies, clearly, all of them showed, I'm sorry that I'm going through rushing through this slide, that none of them showed that amiodarone is any better than placebo in reducing. And this is the final study that was done. If you look at sudden cardiac death and heart failure, this is defibrillator, and this is placebo. And patients with amiodarone is here. So that means amiodarone was as good as placebo in reducing risk of sudden death. And that's why amiodarone is no longer considered a competitor for defibrillator, because amiodarone does not improve survival. But the good news from this study is that it also does not increase mortality compared to placebo. So if somebody has cardiomyopathy and has atrial fibrillation, we can use amiodarone without risk of increasing mortality, as long as we follow the side effect profile. The other situation that we're going to use amiodarone will be somebody who has a defibrillator getting frequent shock from the defibrillator to reduce the number of shocks they are getting. I think we're going to stop it here. Thank you.
That's very, very excellent and specific lecture, I must say. We wanted a lecture from you, sir, due to the specificity, the use, why we should use antiarrhythmic drugs. So I have just another question, sir. If amiodarone can terminate all the arrhythmias for acute setting, rather than trying different things, if one use only amiodarone, be it narrow complex or be it wide complex, what is the harm in it, other than the using brain?
There's a lot of background noise.
Sir, is it audible now?
Yes, go ahead. What was the question?
The question is, for acute termination of any arrhythmia,
yes,
rather than thinking anything else, if someone use amiodarone always, does
Tushar mute হয়ে গেছে।
The use.
Yes. If you, the question is, can I use IV amiodarone to terminate anarrhythmia? If you look at across the board, except ibutalide, the termination rate of AFib or VT just with amiodarone or any other drug is very low. It's in the order of 10%. And most of the time what we do, we give it in combination with defibrillator shock. So if somebody is in VT, I'm not going to give IV amiodarone to convert them back to normal rhythm and wait for the patient to go. So in that scenario, I'm going to do cardioversion. For AFib flutter, we don't use amiodarone to convert. I mean, you have to understand something, that a new onset atrial fibrillation flutter, 50% will convert spontaneously back to sidewalk rhythm within the next 24 hours, even if we don't do anything. We sometimes give medicine like diltiazem, control the rate. Now, of course, one situation that I will give amiodarone IV, let's say somebody comes to the hospital with atrial fibrillation with rapid ventricular response, blood pressure is 110. I cannot use diltiazem high dose. In that case, I can use digoxin or low dose beta blocker. And other situation will be somebody has cardiomyopathy, severe cardiomyopathy, ejection fraction 20%, heart rate is 150, blood pressure systolic is 100. We can't use anything else other than amiodarone. Amiodarone will be a good drug to use as long as you don't bolus to control the rate for the short period of time. Thank you.
Thank you, sir. I'd like to request Dr. Adi sir to say his experience with antiarrhythmics.
I think a few things that on this talk, definitely, I'd like to make sure that amiodarone is not really the first drug of choice. And that's the reason is very specifically mentioned in all guidelines, in US guidelines and European guidelines, because even if for short term, but the medicine is going to stay in the system at least average 3 months. But yes, there's certain niche there when you do use amiodarone, particularly the AFib RVR situation, or that's, I'm talking about narrow complex tachycardia. Then we need to make sure that amiodarone is when you slow down the heart rate and the patient is not on anticoagulation, you always taking the small risk of thromboembolism. But there's some situation we have to do that because you cannot use other AV nodal blocker because blood pressure running low. Okay, like sometimes you give diltiazem bolus that routinely they do in the emergency room situation, and blood pressure drops, then they call cardiology consult. In this situation, definitely amiodarone is a drug of choice. So you can give that amiodarone bolus sometimes, and if there's a concern about too low blood pressure, you can start the drip. But you need to make sure you keep the patient on heparin drip, because still there's pharmacology conversion or electric conversion. We are taking the risk if the patient is not, if you don't know the duration of the arrhythmia, it's more than 48 hours. And also the patient has underlying LV dysfunction, because they are more risk to have atrial appendage clot. So I think amiodarone is a good drug, but that's last resort, you always do, okay? So we have better option. As Dr. Ahmed mentioned, for supraventricular tachycardia, and particularly the AFib, most patients will convert within 24 hours if you just slow down the heart rate, and particularly if the patient is not in persistent AFib. So that we need to strive. And nowadays also another consideration is given. If the patient is in a certain hospital, if they don't convert within 24 hours, then we can think about like transesophageal echocardiogram and cardioversion. So cardioversion, we don't need to forget that it's a very important tool, because when you do the cardioversion, and the patient might be in that rhythm for a while, like atrial fibrillation, and he got used to. When you have cardioversion, the patient feels better all of a sudden. Okay, and the patient tell you, doctor, I feel 100% better, because that's the important thing that you need to tell to the patient, that maybe keeping in rhythm, maybe you will do better, because that psychological concept of feeling better might help the patient more agreeable to be on antiarrhythmic medication. There's one point I like to make, because sometimes patient says, oh, I'll be on antiarrhythmic medication like flecainide or an amiodarone. I don't want that because it's a lot of side effects. But if you can give if the patient needs it, not like on first time definitely use after cardioversion just beta blocker. But if the patient has a recurrent problem, then you need to use an antiarrhythmic medication on. If the patient doesn't have a structural heart disease, class 1C is probably preferable after a cardioversion. But if the patient has LV dysfunction, definitely then amiodarone becomes a choice. But the psychological understanding to feeling better with cardioversion, you need to start talking to the patient. That's the discussion is to be held with the patient, that maybe antiarrhythmic medication he might agreeable to because how he feels better post-cardioversion. So cardioversion has a significant role in the treatment. Absolutely. And
Sure.
One question I have to Dr. Ahmed, if the patient is in pregnancy and atrial flutter and recurrent atrial flutter and no structural heart disease, I know digoxin is good for supraventricular tachyarrhythmias, PSVT or other things, but atrial flutter. So is flecainide, I think, safe to use? Okay.
So the flecainide, I will not use in pregnancy, but today, if it is typical flutter, there are EP doctors who can do ablation without fluoro at all. They can do 3D mapping and do flutter ablation. And I have done it. I mean, you can send this patient to centers where they will do ablation without fluoro use at all.
Radiation much, yeah.
So the one thing that I want to mention, I'll give one scenario of a patient. Patients come to hospital with a rapid ventricle with two symptoms. One, sometimes they come with heart failure symptom. They never felt palpitation. Patient comes to the hospital, heart rate is 140, EF is 20%. Second patient comes with palpitation, some palpitation, EF 20%. Or let's say palpitation rate is 150. Now, the as Aziz mentioned, if patient has cardiomyopathy, then there are two problems. Which one came first? Is it tachycardia-induced cardiomyopathy because patient did not have any palpitation? Or is it cardiomyopathy that put the patient on AFib? So what we do in those cases, we do TE-guided cardioversion and give them heart failure treatment. Let's say after 7 days, AFib comes back. Then what we discuss with the patient that, look, I'm going to use amiodarone for a period of 3 to 6 months. So we will start the patient on anticoagulation, amiodarone, do a repeat cardioversion, and if the EF improves, we stop the amiodarone. So this one, I clearly document in my chart that I'm going to use it for 3 to 6 months so that I remember what happens. And that's how we minimize the side effect of the medicine. So I'd like, Hafiz, any comment?
No, thank you, Rafique bhai. আপনার ইয়ে থেকে মনে হলো যে জ্বরের সময় যে ডাক্তার পরে যায় দেখে তার সে বেটার অফ, কারণ এন্টিঅ্যারিথমিক এবং মেকানিজম অফ অ্যারিথমিয়া লেকচার পরে দিলে লাভ বেশি, কারণ আগের ডাক্তাররা তো মিস করতে পারে। তো আমার কাছে মনে হয়েছে যে এন্টিঅ্যারিথমিক্স এর সময় আমরা যেরকম বন উইলিয়ামস ক্লাসিফিকেশনের ওটা আমাদের মনে রাখার দরকার, সেমনি at the same time যে atrial arrhythmia or ventricular arrhythmia, and then whether this is re-entry or automaticity or triggered. Why? Because when this is purely an EP issue, there is cure, and we should not forget that. So comparing antiarrhythmics with definitive therapy, I think we do injustice to the definitive therapy. Antiarrhythmic drug use in a patient is a bad news in my mind, the more I look at this. And all drugs have side effects, and none works to the way that we want them. Because, for example, in RVOT tachycardia, the treatment is ablation. So anything else is just interim and not the ideal. And the antiarrhythmic drugs classification and availability in Bangladesh, I think, is a big issue, because we cannot do ablation for everybody. At least we control them and make it easier for people to use it outside the big ablation centers. And then probably those who have high risk, recurrent, they may go for ablation. But it is, one thing just comes to my mind, that why we are not able to inspire enough cardiologists to go into EP in Bangladesh. It is mind-boggling to me, because we need to inspire them, because the EP services in Bangladesh, the way that we foresee the need versus the way they are, I think we need to include more people to go into EP. Even I want to do EP now.
Now, it's a very interesting point. I'd like to make some note on that. One that Dr. Ahmed just described, one important subset of patient, that AFib with LV dysfunction, heart failure. That subset of patient, you need to be very serious, because you don't know, that is true, we don't know which was the precipitating factor. Or this AFib is causing the heart failure, long-term tachycardia-induced cardiomyopathy, or cardiomyopathy itself, because of this enlargement of the heart, mitral calcification, regurgitation, fibrosis of the atrium, and left atrium gets bigger, then causing the AFib. But the thing is that if it is tachycardia-induced cardiomyopathy, then it is a retrospective diagnosis sometime. But if you cardiovert the patient and try to maintain in rhythm, good likelihood they might improve. And you do an echocardiogram after 3 to 6 months, and you see significant improvement, you probably save the patient. Okay. And in this type of subset of patients, I really would focus and look at the EAST trial. I'd probably focus on possible ablation if possible. That's the reason Dr. Chowdhury mentioned that, Dr. Ahsan, that we need to, I'm not sure how good this EP is. I know a little bit, but not as much as how good EP services, how aggressive they are on ablation for AFib, like pulmonary vein isolation. That's another thing that probably needs to be developed, because here it's pretty aggressively pursued nowadays in the United States, but I think we could develop that in the future in Bangladesh. And also, if you cannot control, and if that fails, and it's still rapid AFib in heart failure patients, then AV junction ablation with BiV CRT pacemaker or defibrillator placed, that could be another option. But I think I agree with Dr. Asif that we might need to develop more in the EP area in Bangladesh.
Let me make a comment about EP in Bangladesh. AFib ablation, if you look in this country, more than 50% of patients with AFib ablation are back on antiarrhythmic medication. So PVC ablation, AFib ablation, is totally different from ablation of typical flutter or SVT. Bangladesh, if there are 10 EP doctors and they do 1,200 cases a year, which is humanly impossible, it will take 40 years for those 10 EP doctors. If they work non-stop without any vacation, it will take 40 years to finish existing SVT cases in Bangladesh. For AFib ablation, I think what is happening in the United States is we are doing it because it's very good business, because the patients go out, come back, find out how many patients are getting multiple ablations and how many patients have been cured. I'm not saying this is not a modality. It is, AFib ablation is still an evolving modality. Bangladesh is a third world country. Yes, sure. Can we afford a $3,000 catheter for one case in Bangladesh? I don't think so. So I think the focus in Bangladesh should be extending EP service to do ablation of supraventricular tachycardia and typical atrial flutter, which we don't have many in Bangladesh. And that will be the best cost-effective service for a country like Bangladesh. And that can be done very easily. Yes, if somebody wants to marry Angelina Jolie, yes, you can have that dream. But by the time you fulfill that dream, Angelina Jolie is too old. I think we should focus in Bangladesh on SVT ablation. That will be the first thing.
Sir, can I add something?
Sure.
As we are ablating SVT, most of the electrophysiologists in Bangladesh, and the problem first, when we offer the option to the patient who are having recurrent SVT, even with medication, even then they opt for medication, not for ablation. They are afraid of doing this procedure. It's from the patient side. And from the doctor side, what Hafiz Bhai was asking for involving more doctors in electrophysiology, it's not money earning procedure. That's the problem. It takes long time to complete a case. And by that time, one can do 2 or 3 PCA. So that gives more money to the cardiologist than doing a EP case. So and most of the cardiologists do not have that much patience to keep on mapping the pathway for 3, 4, 5 hours. And often, not often, sometimes we do ablation, but on the next day it comes back. Even after working for 5 hours, we succeed, wait for 10 minutes, then give isoprene, wait for another 10 minutes. The pathway doesn't come back. We send to the CCO, and on the next morning, it comes back again. So it is frustrating for the electrophysiologist, also for the patient. So these are the factors that does not attract the cardiologist for make their career in electrophysiology.
You see, a country must have a vision. If we had a choice, I'm sure everybody in this country, in Bangladesh, would like to be a doctor. But then who will farm the land? Who will build the roads? So it's a national policy. Second, a properly done ablation for accessory pathway and supraventricular tachycardia AV node reentry, the success rate should be 95%. With the recurrence rate, we quote, if it is less than that, that means that center is not well trained. That means they need to relook at there. So I'm not saying that skill. Second issue, not every procedure is for diabetes. A guy who is doing intervention should not be doing ablation because it's different. A pediatric cardiac surgeon cannot become adult or vice versa because the hand and the skill and the patience is different. So you need a generation of physicians. Now, will there be somebody? Yes, I'm hopeful there will be people coming to do it because they like it. Like I could have become an interventional cardiologist, but I did not. I like the field. And I did it. Hafiz does intervention because he does and he enjoys it. So it's the vision. Second question is that if you look at the money for intervention, you make more money. Look at where the money is coming from. And there in Bangladesh, there is a tendency to implant devices or do things where there are devices implanted. And there is a reason for it. That reason used to exist in the United States also before, which has been taken away and which is called kickback. In the United States, physicians used to go on tour before 1980s until it was by law, it was made illegal. Bangladeshi physicians, I'm sorry to say this in this forum, people go to conferences. We cannot go to conferences in business class ticket. Bangladeshi physicians go to conferences in business class ticket. Where is the money coming from? You think it is coming from the pharmaceutical industry? No, it is coming from the poor people of the country. And if we change those things, then it will change dramatically because the fee will be same. Thank you.
Thank you, sir, for extensive discussion of antiarrhythmics and pros and cons of career in electrophysiology. After this healthy discussion,
can I make one comment, Rafique bhai, about the safety? So
yeah.
in the VT world or antiarrhythmic world, when we use the dofetilide or sotalol, there is often a term, the reverse dependence use.
Yes.
And that is a concept comes often in the board exam.
Yes.
Because
yeah. That's why I mentioned. I meant if you see that I mentioned I mentioned it. It's a concept. I still find sometimes difficult to grasp, but that's why I'm trying to introduce these terms slowly so that we get used to these terms. Yeah. That why? So thank you.
It's the pharmacology, so it's very dear to my heart.
Well, you are a pharmacology guy. Yes, I have a PhD in pharmacology.
One thing I like to make on this aspect, that's called use dependence and reverse use dependence. The use dependence when patient is tachycardic, that medicine works better. When the patient is bradycardic, that it can cause torsade. Okay, that's reverse use dependence. So when you put the patient on class 3, don't let them go to below 50 heart rate. Okay.
Thank you, sir. It is almost 11
very
p.m. now.
significant practical issue to remember.
Yeah.
Because it is the drug avidity to the tissue with the heart rate, and therefore it has significant safety issue.
As the time is already clicking around 11 p.m., we're gonna stop the program. And in the next
Thank you.
24th September, we're again gonna meet and have an exciting session again. Thank you all the our speaker, distinguished panelists, and the physicians that joined the session. We'll again meet on the 24th September. Till then, thank you all for joining. And again, thanking Vaccine Pharmaceuticals for their logistics support and the continuation of this program. Thank you all.
Thank you, Tushar.